Our next presenter is Elisa Hamilton. Elisa is a doctoral student studying systems engineering at Johns Hopkins University, and she will be presenting on gender-responsive dynamic models of COVID-19, HIV, and malaria transmission, a systematic scoping review.
Before I became a modeler, I was actually an art therapist, and I worked mainly in pediatric oncology and deaf education. And a lot of people are confused by the switch from art therapy to system dynamics and systems engineering. But I'm very excited to be part of this session today because I think all of you, especially in the HIV world, understand the connections between social determinants and infectious disease outcomes and mental health and well-being. And I think that there's a lot that modelers like myself, who mainly work with respiratory diseases, can learn from you all when it comes to health disparities. So I hope that's one of the takeaways from my presentation today. There we go. First, I'd like to thank all of our collaborators. This was a collaboration between the Bloomberg School of Public Health and also the Whiting School of Engineering. And today I am going to introduce the MAGE project. And then also introduce the MAGE project's gender-responsive M&E framework. I will go through our inclusion criteria for the scoping review with an example study, and then I'll go over some preliminary results. So MAGE stands for Monitoring and Action for Gender and Equity, and it's a partnership between the Global Financing Facility and Johns Hopkins, and it's funded by the Bill and Melinda Gates Foundation. And in collaboration with GFF country clients, MAGE aims to strengthen gender and equity M&E, develop and act on gender and equity M&E, and also promote increased understanding of gender data and evidence. And so this is the gender responsive M&E framework that was developed as part of the MAGE project. So if we're looking just at indicators that are related to humans, an entry point into being gender responsive is to be sex or gender specific or sex or gender disaggregated. And so sex or gender specific would be having an indicator that's only looking at one gender group, for example, women, whereas sex or gender disaggregated would be stratifying that, for example, men and women. And we say sex or gender, with sex referring to biological factors and gender referring to social factors. And then gender dimensions that can increase responsiveness are needs, rights, and preferences, as well as power relations and systems, and I'll define these in a bit. And then actions and proactive approaches to increase responsiveness include taking an intersectional lens by stratifying by another social stratifier, for example, age and race, including meaningful participation from target groups like women and girls, and then also taking into consideration context and local gender systems. So now I'm going to define these gender dimensions because they're relevant for our inclusion criteria. So needs refers to what a sex or gender-based group needs in terms of health services. So an example of this would be maternal and child health services. Rights refers to what a sex or gender group has a right to in terms of health services. And an example is the SDGs and the universal human right to gender equality and health. Preferences refers to what a sex or gender-based group prefers in terms of health services. And this could be having women healthcare providers or a chaperone during an examination or having private examination rooms. And when preferences aren't met, they can act as barriers to utilization and access. And then power relations and systems considers the ways in which inequities manifest in a number of things such as access to resources, roles and practices, norms and beliefs, decision-making, as well as institutions, policies, and laws. And so examples would be, in some contexts, women need permission to leave the house, or in others, a certain gender group may not have a lot of agency in initiating condom use. So from this, we branched off and asked ourselves, how can infectious disease models be more gender responsive? So we know that there are gender disparities in infectious disease outcomes, for example, HIV among men who have sex with men. There's also evidence of that with COVID-19. And our hypothesis is that gender responsive models can be more informative for decision making, and it can help us better tailor interventions and target resources to decrease disparities. So our main goal was to provide examples to modelers about how a study can be gender responsive, and then also map out a process of what is considered a gender responsive approach. And so we had 6 inclusion criteria, which I'll go into detail in a bit. But first, we were looking only at dynamic models. Second, we wanted to find disease-specific health outcomes of COVID-19, HIV, or malaria. We wanted the studies to stratify their populations by sex or gender, and also an additional social stratifier like age or race. And then that stratification needed to be maintained throughout the entire study, and they needed to include those gender dimensions of needs, rights, preferences, power relations, and systems. So these first 2 are referring to mechanistic infectious disease models, and then the next 3 are entry points into being gender responsive, but they're not exclusive to gender responsive studies. So that's a really important disclaimer of our review. We're just capturing a subset of studies that are gender responsive. So now I'm going to go through each one of those and give some examples and justifications with this example study, achieving the ending the HIV epidemic in the US incidence reduction goals among at-risk populations in the South. So our first inclusion criteria is that it needs to be a dynamic model. And by this, we're referring to compartmental models, agent-based models, and others. And that's because we know that many HIV models are ABMs, and then many COVID and malaria models are compartmental. And this was a way to narrow down our search. So we're excluding all statistical time series models, which very well may be gender responsive, but there are a lot of studies out there and we needed to narrow things down. So our example study here is an agent-based network model, so it meets this inclusion criteria. Next, we want studies that look at disease-specific health outcomes of COVID, HIV, or malaria. And that is because instead of looking at all diseases, we needed to narrow things down. So we said, let's focus on 3 different transmission routes: respiratory, vector-borne, and sexually transmitted. And then these outcomes here are common in forecasting and scenario modeling. We also thought that there would be good examples in the HIV literature that could be used in malaria or COVID-19. And again, this was a way to narrow down our search. So the example study is simulating the HIV epidemic in the South, so that would meet this criteria. Next, we wanted the study to be sex or gender disaggregated. So examples could be having different compartments for men and women or transgender women. Maybe you do whole separate model runs for different gender groups, or if it's an ABM, you could have agents with different attributes of gender, etc. So this was a way to make our transmission routes more comparable. So you're unlikely to find a gender-specific COVID-19 model, but there are a lot of gender-specific HIV models. So we're just looking at the differences mainly between men and women, but our search did capture some studies looking at other gender groups. And then again, this was a way to narrow down the search. So there are a lot of sex-specific studies out there. So that would be if the population was just focusing on one gender group that are gender responsive, but they would not have been captured in our search. So our example study is an ABM, and they have attributes for age, sex, and race. So we also see that it meets the 4th criteria, which is to have an additional social stratifier. So you could have this as an age and gender structured compartmental model or an ABM with different attributes. And we were looking at identities that are important in systems of power and also transmission. And you can see some others here. And this is somewhat subjective, and I'm sure you can think of others, but we tried to be as systematic as possible. And we wanted to include an additional social stratifier because it's a way to take an intersectional framework, so intersectional lens, so going back to the M&E framework. It can reveal compounding inequities, and it's important for decision making. So for example, if you are looking at outcomes stratified by gender, say men and women, and you notice there's increased burden among women, and you take that extra step to look, okay, actually the burden is more focused on women of a certain age bin. If you're not taking that extra step, you may be allocating resources or targeting of intervention to all women, which would not be as efficient or potentially impactful if you were targeting it to women of that certain age group. Next, that stratification needed to be maintained throughout the entire study. So it's not enough to have an ABM where you have agents with attributes for age, gender, and race. We actually want to see outcomes for those different groups in the results. And that is, again, so we can actually find them. So maybe you do that, you do all of the stratification, you run the analyses, maybe you don't find any differences, but if you hadn't looked, you definitely wouldn't have found them. So even you can put those in the supplement if you don't find anything, but it's important to do them. So here's an example of how the study did that. In a table, they're looking at reductions of HIV incidence among MSM here, and they stratify this by race. Finally, our most nebulous inclusion criteria: needs, rights, preferences, power relations, and systems. This is also subjective, but we did our best to think about ways that studies could do this. So one would be having it thought out in detail in the introduction or discussion, or maybe they're taking context and consideration when they're designing their scenarios. They may also propose interventions or policies that take these things into account. And it's important to include these because it's a way of explaining why disparities exist. It considers context. And again, important for decision making. If your interventions or your if your interventions don't take into account needs, rights, and preferences, then they're not going to be impactful because people probably aren't going to be as receptive to them. So in this example study, it states that non-Hispanic Black women are an overlooked population with unique challenges for HIV prevention, including access to healthcare and other supportive services that enable women to exercise agency. So that term agency is going back to how inequities can manifest in decision making. Another way that this study did this was that it proposed interventions in the discussion in a way that considered context, and it also gave examples of interventions that already exist that have seen some success with these population groups. So now I hope you have an understanding of the type of study that we were trying to capture in our review, and I'll go through some preliminary results. So our total database search captured about 10,000 studies, and then once duplicates were removed, we had about 6,000 studies. And then we screened all of those and found about 1,000 that were qualified for full text inclusion. And this is an ongoing review, so we still have some work to do, which you can see here in purple. And right now we're in the data extraction phase. So now if we just focus in on those 1,000 for full text, to be considered for full text, you just had to be a dynamic model of HIV, COVID, or malaria. And that's because you can't always get information about those other criteria from the abstract. So we went through all of those and we found about 500 that were sex or gender disaggregated. And then we went through all of those and found about 200 that had an additional social stratifier. And then we went through all of those to see which ones actually maintain the stratification. And you can see that there's a lot more representation from HIV, followed by COVID-19, and then not very much from malaria. And in our final studies, we don't have any malaria studies. So I know this is very small, but it's just like a snapshot of what our data extraction will look like. In addition to the disease, the model type, the stratification, we're also looking at explanations of why disparities exist, the findings of the study, and then any implications for decision making. And to me as a modeler, this is very useful because I can think about my research question and then I can see examples that might be related. And I can look at, okay, what kind of model did they use? Is it open source? How did they generate their population? What scenarios did they run? So that's very exciting to me. And it goes back to our first goal of providing examples. And then our second goal was to map out a process as a way to be gender responsive. So here's some things that we came up with. Disaggregate by sex or gender when applicable. Disaggregate by one or more social stratifier to take that intersectional lens and to reveal any compounding inequities. And then also maintain that stratification and incorporate those gender dimensions. So again, this is not the only way to be gender responsive, but it is a way. And finally, so now we have this review, we've come up with all of these studies, we've mapped out this approach, what do we do with it? So personally for me, I'm doing some retrospective COVID analyses looking at health disparities. So I'm going to be using this framework in my model building. And then also, I think it would be interesting to go back and look at how many of those studies were actually used in decision making and did they talk about that in their paper? I think there are probably some spatial and temporal trends with regards to what data is available and also health system infrastructure, and then also with increased computing power. And then I think that this framework could also be expanded beyond infectious disease mechanistic models. And then I would like, if the data is available, I think it'd be interesting to look more at things like urbanicity or education, most of the extra social stratifiers that we found were age, race, and sexual orientation. So that's all I have for you today. Thanks.
Thank you, Elisa. Do we have any questions in the room?
Then you understood everything.
Thank you so much, Elisa. I liked the whole idea of power relations, trying to understand it. Maybe you could just let us know how exactly do you want to, or maybe through your literature, what are some of the power relations aspects that you picked?
Well, initiating condom use was one that came up. That's the only one I can think of, but I think Sally's presentation was a really good example of why those things should be considered in terms of decision making.
Hello, Elisa. I also had a question regarding how, I'm not sure if you saw how many of those papers had conceptual frameworks. And I was wondering how you felt about that as an important part of model building, like having that inform, and also like in that case, how you see the needs, preferences, systems influence that framework development.
Yeah, I think that's a really good point. And I think in the system dynamics literature, you're more likely to find those conceptual frameworks and causal loop diagrams. I can't think of a lot that came up in our included studies, but I think that approach to model building is definitely useful when you're thinking about context and stakeholders who are involved in the actual health system. So yeah,